Our next question is define oral bioavailability. Describe the fraction that influences oral bioavailability. Use one example to illustrate the clinical application of oral bioavailability. All right, so how we're going to structure this question, we're going to give a definition, and even though the definition is only 10%, it'll be good to put the two equations. We'll talk about that. Then the part B was describe the factors which influences the oral bioavailability. So that's the majority. So that's 80%. And you can talk about the equation, especially the second one, in terms of. So the way I've split this is drug factors, okay, and patient factors, and also when you talk about the patient factors, you talk about the HER, so you talk about GIT and liver, which is where you talk about the bioavailability or the first pass metabolism. The first pass metabolism, you're talking about GIT and HER. And then the last part was give an example, which is 10%. So giving an example is just morphine or furosemide, midazolam or furosemide. Okay, so let's go through the definition. What is the definition? So the definition is the fraction of the drug that reaches systemic circulation after passing through the GIT. The equation is bioavailability is oral AUC over IV AUC, where IV is 100% bioavailability. The other one is F times 1 minus HER, where F is the fraction absorbed HER's hepatic extraction ratio. So this is really important. We're going to talk about why. Okay. So then we talk about drug factors. So again, Fick's law, very easy. We know Fick's law. Increased drug concentration increases diffusion, increases solubility, increases diffusion across the lipid. Example, propranolol. Increases lipid solubility, increases ionized fraction, increases surface area, decreased thickness, such as edema in heart failure. And the surface area is decreased diffusion with gastric bypass, for example, or a small bowel resection. Okay, so I've just drawn a little diagram there because I know that I will forget that small bowel restriction thing, but that's going to remind me. Reduce molecular weight, it increases diffusion. Okay, so that's quite easy marks there. Then we talk about patient factors, and patient factors is two factors. So there's metabolism of the GIT wall, and there's the liver, which is usually phase 1, phase 2. GIT, the way you think about GIT, what does GIT have? It has blood flow. So increased absorption if there's increased blood flow. It has gastric emptying. Why does it have gastric emptying? So we love talking about gastric emptying. So decrease or delayed gastric emptying will delay the drug. So an easy way to do it is just write delay. So delay gastric emptying, delay drug. You want to be so specific. Entering the small bowel, slower the absorption. Then you have GIT transit time, so decrease intestinal motility, increase exposure to the duodenum, increases absorption in the drug interaction. So if you decrease the motility, you have more exposure to your duodenum, and then more drug is absorbed. And then PPI, for example, is drug interaction. PPI, which is a stomach acid, and it's less acidic. So this is more of a drug interaction, but it's also patient factor. Then you have fraction, decrease absorption, and then diseases. Oh, sorry, I'm saying sorry. Decrease ionized fraction, or let's just make it simple. Ionized percentage. That's it. And then you have diseases, which is something like celiac disease. I'm actually in the clinic right now, Gan's clinic, and he has celiac. So that we can remember that. Celiac disease, malabsorption, or shock states, or diarrhea, which increases the GIT time. So we can link that one to that one, okay? And then we talk about the liver stuff. So we can talk about the equation here and increase HER. When HER is greater than 0.7, then it's perfusion dependent. When HER is less than 0.7, you decrease bioavailability, decrease first pass metabolism. That's actually not correct. Decrease HER, you increase bioavailability from the equation. You decrease this, you're going to increase that, okay? But the first pass is opposite. This can be confusing. Bioavailability is opposite to first pass. Why is bioavailability opposite to first pass? Because first pass metabolism is where it gets into the liver, and then that's where it gets metabolized. Bioavailability is how much is left. So if it's going to get metabolized more, then there's going to be less left. So they're always opposite. Okay. So drugs with increased liver enzyme induction, which means that it's going to metabolize more, then you get increased first pass, decreased bioavailability, such as phenytoin. Warfarin, amiodarone, ETOH is an inhibition. So you got worsening liver enzymes. The example we talk about is furosemide, which is 2-to-1 ratio. So warfarin is an inhibitor, by the way. So I'm not sure. So you can say warfarin here, warfarin, amiodarone. The only one that's inducing that I know is phenytoin.